next presentation. Basically, this is a case-based discussion. And can you open that presentation? So this discussion is to basically to stimulate the thought process. So on the case slides, you will find that we have categorized these patients, that is the, the background of patients in 5 different, categories. So can you elaborate on that, Dr. Nidhi?
Yeah. So we'll start with the first case. We'll be talking about these factors: the patient, what is the age of the patient, what is the occupation, and the fellow eye, biometry, occupation, hobbies, and ocular problems. So we'll start with the first case. She's a 60-year-old lady. She has significant cataract in both the eyes. She doesn't have any main astigmatism. She's a housewife, and she does minimal reading and housework and watches TV, and there is no other ocular problems. So
so how many would like to go for a EDOF IOL in this patient? You can raise your hands. And how many for trifocal? Yeah, more for trifocal. Okay, panelists?
Now the photo you have shown is a near mature cataract, and if
Yes.
you can't see retina clearly, I will never do a trifocal, because monofocals and EDOFs are far more forgiving, because you even on a USG B scan you will miss subtle things like a VMT or a ERM, and I won't do a trifocal because I won't be able to see a fundus clearly in this kind of a cataract.
Okay, Sean?
Yeah, I agree with Dr. Nitin. Actually, things depends on her socio-economical status. First, I think she is from poor this thing. So, if monofocal, if they are willing for trifocal, it's good. As sir said, it's a mature cataract, but sometimes in this age we can at least accept that much, and patient can, if the choice is between EDOF and trifocal, the choice will be trifocal. Thank you.
Yeah. Go to the next slide.
So this is a 65-year-old lady with other eye is normal in this case, and it is emetropic, 6/6 vision. Rest of the things are same.
So now the things which have changed is that the fellow eye had changed. Okay, so we are going stepwise. Earlier, all 5 categories you have seen. Now the fellow eye is normal, emetropic, that is 6/6. So Nitin, what is your choice?
Now, if you do a trifocal in the other eye, it's going to take a lot of neuroadoption, a lot of counseling, and won't be easy for the patient to adopt with one eye emetropic, normal eye, and other eye trifocal. I think EDOFs will be far more forgiving in such situation, or a monofocal straight away. If again we have to give a choice to the patient, monofocal or EDOF, but I won't hesitate doing a EDOF because they neuroadapt very well, and they don't perceive those kind of aberrations in one eye to be really unhappy.
Sean, any other view or same?
Same.
So these patients typically have unique symptom afterwards. They do this.
Yes.
Okay. So this is a very unique symptoms these patients have. So always, consider the fellow eye vision when you are considering any surgery for the, eye having cataract. Next, Nidhi.
So this is a 60-year-old farmer, and who has the other eye early cataract, and he also drives occasionally at night. The rest of the things are same.
Yes. So things which have changed now, that fellow eye has early cataract, and farmer male and drives occasionally at night. So Sean?
For me, if occasionally he's driving, that can be taken care. Multifocal is also a choice. But as a farmer, if he don't want to read, but need some other things also, trifocal, or good for EDOF patient also, if we are considering this both. Otherwise, monofocal is my choice for this
Monofocal,
patient.
okay. Nitin, anything else?
So luckily we have large range of lenses available now. So socioeconomic status is not really a hindrance nowadays for the lens, because we have great Indian EDOF lenses, we have great multinational EDOF lenses, I think, and the forgiving nature and good quality of vision. So generally I have moved away from trifocals now. I am doing only EDOFs or monofocals depending on the patient condition, because as I showed in my study, patients are largely independent even with EDOFs from glasses.
Dr.
And
Nitin?
what I have noticed is that having hypermetropia in the other eye actually is useful. Because they have
Yes.
poor distance as well as near quality. So that, always patient compare with the fellow eye. That's thing we have to understand. So that is the thing which is available for comparison, and comparison is the thief of joy. So even if you do the best surgery and give a very good vision, if the fellow eye has better either near or distance vision uncorrected, probably patient may not be that happy.
And if distance is +1, I will prefer trifocal for these
Trifocal
patients.
for this, yes. Okay.
So occasional driving, are you okay with trifocal, or even in occasional driving you
I have
avoid?
seen so many patients, ma'am, they are using trifocals, but after 2 to 3 months, they are used to it. So that is not an issue. That is not a phobia to have this. That's all.
Yeah, I am also quite happy. Occasional night
Yes,
driving, I think,
yes.
is quite okay with trifocals. Next, please.
So this is 65-year-old man who is a teacher by profession. Other eye also has cataract. There is some against the rule astigmatism, and he drives at night and also reads, of course.
Okay, so here I think one difference is probably the astigmatism of 0.75 diopters. So how many of you will consider a toric IOL in this particular case? Others will go for some other, or they will just do steep incision. 0.75 diopters against the rule. Yes, so Nitin, you are cut off for using torics?
Even if it's 0.5, I put it in the toric calculator. If toric calculator says toric, I put toric. So I think you have to be least tolerant to cylinders, and you should treat them whenever possible. So either it could be a LRI for such a small power, but I think toric lenses are far more accurate. I would prefer that.
So I think one thing to remember is that 0.75 or even 0.75 diopter residual cylinder reduces the contrast in the same way when you compare monofocal with trifocal. Okay.
Right.
So if patient has monofocal with say 1 diopter cylinder and patient sees uncorrected, he will have less contrast similar to a trifocal patient. So we don't, in trifocal we are already reducing the contrast a bit. So we don't want anything to further aggravate that situation. So whatever small cylinder is there, we have to aim that post-operatively patient should have less than 0.5 cylinder. Next slide.
Now this patient, again, same things, only thing he has, he's diabetic and he has mild NPDR, the macula is normal.
Yeah, so that is another thing which we come across a lot. We have many diabetic patients. So shown mild NPDR, 65-year-old, macula is healthy, no problem. So will you go for either EDOF or trifocal in this case?
I will go for EDOF because even though this is normal now, but in future there may be a chances of diabetic retinopathy in that case.
Same,
So
Nitin?
EDOF will be my choice.
Okay, next slide, please. Another thing, the same thing, but we have changed the age of this patient. Earlier it was 65-year-old, now it is 45-year-old, okay, and teacher and hobby is basically for near work. So she wants to get rid of glasses, okay, but she is diabetic and has mild NPDR, macula is healthy. Only thing we have changed probably is one, she wants to get rid of glasses, but she is 45-year-old.
Something like a minival proxa, because minival, as I showed you, has a good MTF, good strain ratio, and the non-dominant eye would have a proxa which gives N6 by rule usually, and this combination works really well, especially for people who don't want to wear glasses.
Yes. So one thing to understand is the age of the patient, particularly diabetic patients. See, 65-year-old diabetic patient is least likely to have, progression of diabetic retinopathy. But 45-year-old lady, we definitely know that she is going to need treatment somewhere down the line. So we'll either go for like the mix and match or monovision kind of. If she is really, like sir was saying, monovision might work even well because she really don't want to use specs, but we want to put more of a monofocal or maybe a low ad EDOF. Next,
Good
Nidhi.
counseling is more important in this case.
Yes.
Now again,
Sir.
Yeah, toric we have cleared that. So we have to use toric.
so 50-year-old lady with other eye also cataract, and main thing different is she's working, she's HR manager and she has dry eyes.
Yeah,
And she
dry
does
eyes.
mainly near things and intermediate also.
So Nitin, you have, I think, operated many HR managers already.
So dry eye
probably
workup is
CEOs.
very essential when you do any premium lens, anything, any EDOF or a trifocal. So you have We do tear film analysis. If there is a tear film issues, which is we found in 30-40% of our patients, we do treat it, and then only because this 0.75 such small cylinders are deceiving in dry eye eyes, you know. So unless you really manage dry eye well and then do your biometry correctly, and then if you get this, then and again, trifocal lenses with a bad tear film is a nightmare. EDOF and monofocals are far more forgiving. HR person would be a lot on computers.
Yes.
So I think EDOF would be a choice, provided your tear film is stable.
So I think the occupation mainly tells you what is the working distance for that patient. That is something you have to always keep in mind while operating. Dry eye is another problem. I recently operated a doctor, okay, and I used EDOF IOL bilaterally. And after a week, she called because she was not planning to come back to see me, just see locally. After a week or so, she said that I am seeing everything very blurred. I cannot see well. So I said, just come down. And I saw that the eyes were very dry. The reason is that the next day post-op, she was seeing so well for the near. She continuously watched mobile phone for all 7 days.
Yeah.
And the eyes became very, very, very dry. The moment we started dry therapy, vision became all right. So I think that is also something we have to be aware of.
So very common scenario now, 50-year-old software engineer who is into trekking and mobile use, and the other eye is completely normal. She has dry eyes because of the screen use, and so what do you go for this?
So these are nowadays very common patients, younger patients who are quite outgoing, a lot of outdoor activities they are doing, a lot of dry eye because of the gadget use. So Sean, will you go for a trifocal or monofocal, EDOF, lot of choices because most of them have, can pay for anything. And this lady has another other eye vision, uncorrected 6/6.
I think EDOF will be a choice for me, but depend if lady is there and she don't want to drive, so trifocal will also be a choice for, but depending on.
Another important thing which I have mentioned is that 0.75 diopter with the rule astigmatism. Any concerns about that?
Right.
So so this is one of the issues which I have found, that few of these younger patients, they have with the rule astigmatism, and you usually do a temporal incision which reduces the against the rule astigmatism, but it will induce more with the rule astigmatism. So you have to always use the toric calculator, and if your incision is going to increase this with the rule astigmatism, patient may land up with more astigmatism post-operatively. So make sure you take either a steep axis incision or use a toric IOL in this case.
Yeah, that's very important. So now we change the occupation only, other things are normal. She is a 50-year-old man who is a politician, and he does night driving also occasionally. The rest of the things are same.
Sean, he is a leader himself, so how
Leader
do you
don't-
tackle the politicians?
Leader don't want to change their facial expressions, spectacles, because their photos are always on the banners and all. So whatever we will put them, they will ask to have specs for them. So this is a big issues for the politicians, because they don't want to change their face. Because if we will say you don't have to wear specs, they will say no, I have to wear specs. Otherwise, how people will recognize me? So this is choice. All choices for me, it's monofocal.
Monofocal or EDOF.
But EDOF is another choice. Trifocal I will not prefer.
Okay, you don't want the politician to come back to you again and again with
No,
complaints.
it's not like
of-
that. If they will come, definitely 4 or 5 patients will also come with them. So no issue. Financially, it's good.
Good. Next.
Now this is also a common scenario, a young patient with other eye of course normal, and with traumatic mydriasis, and the student is active physically and also drives at night.
This is another common thing. Young unilateral cataracts. Also, Fuchs iridocyclitis many times missed in these young population who come with unilateral cataracts, and usually also the traumatic mydriasis is missed many times, and post-op patient has problem. And they want the best, usually their parents or, they want the best lens for their kid. So what is your choice in this particular scenario?
I will definitely not take EDOFs with central bumps, because they are largely pupil dependent kind of lenses. Something like a PRC where the there is a subtle refractive change all over the optic, and not or something like aberration based lenses without bumps, you know. So those two lenses, hydrophobic lens would be great if there is some uveitis. So I think my choice is obviously EDOF, because we have very strong EDOFs now which give a large independence, but something without bumps, you know, so something more uniform optics which are pupil independent.
So somehow, me personally will go for a monofocal plus kind of IOL, which has slightly little, you know, intermediate vision, but I won't go for a trifocal or even a hybrid EDOF kind of thing, which has a lot of elements on it. Next, Nidhi.
So it was mentioned earlier,
Yeah,
a patient
Fuchs,
with Fuchs.
Many times in OPD it is missed, and on table you suddenly see on table that there are these KPs. So one has to be very careful.
Now, this is a patient with both eyes cataract, and she also has moderate glaucoma. She's a housewife.
So I think this is for Dr. Nitin. He's a glaucoma specialist as well, so must be seeing a lot of glaucoma patients.
Yeah, in mild to moderate glaucoma, EDOFs do really well. There is no issue at all. I have done lots of mild to moderate glaucoma patients. I have done EDOFs in them. When the glaucoma is advanced, I will do only monofocals, because they have very restricted field, and we don't want any lenses that play around with the optics. So
I think
simple monofocal in advanced, mild to moderate, they tolerate EDOFs really well.
Yeah. So let the entire light reach, you know, retina.
Again, a common scenario, a 70-year-old retired person with diabetes and early ARMD, and both eyes cataract, but he's reading and driving at night.
So ARMD, again, we see many patients with early ARMD. They don't have vision loss because of the age-related degeneration, but, you know, Sean, you change your, you know, choice. Like patient wants that probably I don't want to use specs. So do you change based on the ARMD stage or something?
And the age is also 70, so we should consider this. We can go ahead for EDOF lens in this case.
Nitin?
I would prefer monofocal, something like a Technis that gives great contrast at night also. And I think diabetes is affecting periphery, AMD affecting center. Anything that reduces contrast should be avoided, I think.
Yeah. In ARMD, what we see, you know, physically on fundus camera is many times is less as compared to what is happening physiologically inside. Like RP is already degenerating, their light sensitivity must have reduced already. So I would like to avoid trifocals. We had a patient very close to, you know, me, and they missed the macular drusen, like it was a ARMD, and went for a trifocal. The adaptation period was very long. Like she took like 3 months to get, but she got to 6/6 N6, which was the potential vision. But the adaptation period was very, very, very long. So I think that has to be, you know, kept in mind when we are going for ARMD.
So there was a study in 2024 about performance of the EDOF lenses in eyes with pre-existing retinal diseases, where they compared the normal eyes with the retinal diseases, mild retinal pathologies. And it was found that if, these patients were also happy, and almost 70 to 77% of these patients would choose this IOL again. Although, of course, compared to normal eyes, their vision was slightly less and there were more photopsia, but the patients' satisfaction was high.
This was with EDOF.
With EDOF,
okay.
yeah. So this is also a common scenario. Fellow doctor, surgeon, 50-year-old man, and he also drives occasionally, and he's a pre-diabetic. Other eye is almost very low cataract, and he comes to you for surgery. So general surgeon, young patient.
Yeah, Sean? So again, another common thing which we see, like our fellow surgeons, once we become expert in our surgeries, our fellow surgeons come to us and they want everything, like, you know, distance clear vision, they want near vision also uncorrected. So a general surgeon here who is still active into practice. So Nitin, you would like to go for premium or EDOF or trifocal or just a monofocal in this case?
If I consider my eye, I will definitely go for a EDOF because it gives me better contrast, which is very, very important. A good EDOF with a best trails ratio is something that I will go with, because ultimately it's visual quality. For very occasional near work, you can always have some additions, but overall my patients with EDOPS are much more happier, and I have already stated that I have reduced my trifocal use drastically.
Thank you, Nitin. I think because we have already exceeded the time, we'll stop here. Thank you so much, all the delegates who have attended the